I think it's Ms. Hewitt, you are on then.
Okay. Thank you so very much. Good morning, ladies and gentlemen. I am Carolyn Hewitt, President of the East Oakland-Hayward Section of the National Council of Negro Women, Inc. It is my pleasure to welcome you to this virtual town hall. Can we afford to wait? Addressing African Americans about the COVID-19 vaccine. This is an event we are hosting in collaboration with Brother to Brother. Our goal today is to provide you with informed, current, and valuable information about the COVID-19 vaccines. Of course, we urge you to confer with your physician or healthcare provider before taking the vaccine to discuss your personal medical conditions and history and any particular issues you may have, including diabetes, medical treatments, pending operations, etc. The National Council of Negro Women, Inc. is one of the nation's oldest nonprofit community-based membership organization for African American women. NCNW was founded in 1935 by the renowned educator and activist, Dr. Mary McLeod Bethune, and has more than 220 sections located throughout the nation. The mission of the National Council of Negro Women, Inc. is to lead, empower, and advocate for women of African descent, their families, and communities. The East Oakland-Hayward section of NCNW has been fulfilling this mission by providing programs and services to this community for more than 50 years. Some of our projects include this virtual town hall and other community presentations, providing hygiene supplies to homeless women, donating food, clothing, and housing supplies for our veterans, providing training supplies to the local Boys and Girls Club, and we assist in the support of people living with AIDS and HIV in Zimbabwe by purchasing vitamins to boost their immune system. Please check us out on our website, eohncnw.org. I also invite you to join us via Zoom on the first Saturday of each month at 1 p.m. Again, welcome and thank you for joining us. Now you will hear from my brother, our brother, Merlin Edwards of Brother to Brother.
Thank you, Carolyn. My name is Merlin Edwards, and I've been with Brother to Brother for well over 10 years. Our objective today is to not only talk about the vaccine, but to emphasize how important it is, particularly for African American men, to make sure that they get the vaccine and understand why we're getting the vaccine. So it is a pleasure for me to join with the National Council of Negro Women as a member of Brother to Brother and as Brother to Brother is helping to sponsor this event. We're not just a group of men that come together on Tuesday night to Bible study. We do much more than that. We're very concerned about the health of African American men because many African American men neglect their health. And so we talk about that quite a bit. And as I said, we not only do Bible study, but we also participate in a program for African American young men because they do need the guidance of many of the more elderly or mature men in our neighborhood. So we provide a service to them. We also do a thing on Christmas and on New Year's. We give gifts and money and food to the people who many times cannot afford to enjoy the holidays as many of us do. But we do something special. This year we've started, actually last year, we started a class on African American history. All is a part of what we do, and we extend that gift or those presentations to anyone who wants to attend those classes. And then we don't totally eliminate the women because they play an integral part in Brother to Brother. When we first started, there was an older woman who prayed for us every night while we were having Bible study. And we honor her all the time because of her prayers. And then there was another woman who, unfortunately, both of them have passed, but Herb Lofton's wife felt that we should feed these men because they're coming from work. So for as long as she was alive, she actually cooked a full course meal for all of the men that were there. We started off with 15, it dropped off to about 4, we went back up to 8, and now we average about 40 men every Tuesday night. And now that we're on Zoom, we actually host about close to 100, maybe about 125 men every Tuesday night. So we're honored, we're pleased to be a part of this presentation and to talk to our African-American men in terms of how important it is for them to take care of themselves medically. So at this point, I'd like to introduce our moderator, Mr. Kevin Blackburn, who's also a member of Brother to Brother.
Thank you very much, Merlin. And let me add my welcome to those of you that have taken time out of your schedules to join us this morning. Before we begin, let me just go over some ground rules regarding the Zoom meeting and our panel discussion. First of all, some of you are very familiar with Zoom and how it works. Some of you may not be. So we want to make sure that this is a conversation, and we want you to ask questions, and you can do that in several ways. Some of you have already submitted questions in advance, and we thank you for doing so. If during the discussion you have a question that you would like to ask, there is a Q&A box. If you're on your computer at the lower portion of your screen, please enter your questions there. If you are directing your question to a specific panelist, it would be very helpful to put their name prior to the question. And then each panelist will have about 15 minutes for their segment. And following the conclusion of their segment, we'll respond to specific questions for that panelist. After all of the presentations are complete, we'll open it up for additional questions. And just as a reminder, you don't have to wait until the end of the program to submit your questions. For those of you that are calling in on your phone, we would like everyone to mute. And if you're on your computer, there is a microphone icon that you can click on, and it will close off your mic so we can eliminate background noise. And if you are on your phone, you can mute by pressing *6 and unmute by doing the same, *6. So thank you very much for your cooperation. And now we can move on to the program. On January 30th of 2020, the director of the World Health Organization declared the COVID-19 outbreak a public health emergency. And then 40 days later, on March 11th, 2020, the Director General of the World Health Organization declared the COVID-19 virus a global pandemic. During the relatively short period of time between then and now, in the US alone, 27.5 million people have tested positive for COVID-19 and 481,000 people have died. That's 27.5 million people, if I didn't get that right, and 481,000 have died. And then in California, 3.5 million have tested positive, with 46,435 people having died from the COVID-19 virus. Against that backdrop, the medical and scientific communities have moved heaven and earth to develop a vaccine in order to combat the effects of the virus. And the FDA has granted emergency approval for 2 vaccines to be used in America, the Pfizer and Moderna vaccines. Our objective today is to provide you, as has already been stated, with factual information from leading health experts so you can make an informed decision whether or not you should get vaccinated. To borrow a line from Shakespeare, to be vaccinated or not to be vaccinated, that is the question. And now it is my distinct privilege to introduce our panel this morning for this morning's town hall. We have 4 distinguished panelists that will be providing pertinent information on our subject today. Our first panelist is Ms. Dorothy Poston. We then have Dr. Kim Rhodes, Dr. Michael Lenore, and Ms. Kimmy Watkins Tart. I will give you a background of each of them prior to their presentation. And so for our first panelist, Ms. Dorothy Poston is a native of Oakland. Although she's retired, she's on a temporary assignment serving as the director of the West Oakland Senior Center. Ms. Poston is a licensed, ordained minister and certified as a national health care provider serving in Las Vegas, Nevada. Presently, she is Secretary of Women United Domestic Violence Awareness in North Las Vegas, and as a consultant to One Community, a nonprofit agency also in Las Vegas. Ms. Poston has 3 children, 6 grandchildren, and 1 great-grandchild, and she is a COVID-19 survivor. Please welcome Ms. Dorothy Poston.
Thank you, Mr. Blackburn, and thank you for allowing me to be part of this panel discussion. I am an annuity for the city of Oakland, living in Las Vegas, Nevada. Last February, I was asked to return to work in Oakland. My plans were to stay with family in Oakland and come home every other weekend. However, on March 7th, some family members and I came home to attend another family member's funeral. I was told there were approximately 700 attendees at that funeral. One of my relatives was coughing a lot and complaining about her chest hurting. We thought it was just her asthma. Sometime mid-March, the county issued a mandatory shelter in place. Consequently, I worked in the office alone. During the 3rd week, I remember going to the clinic due to some extreme lower back pains. Since I didn't have a fever, I was prescribed some pain relievers and told to rest. That worked for about a day or 2. I remember being at work, returning to work and having extreme back pains with diarrhea. It seemed like it took hours to gain my composure just to drive back to my cousin's house. As the night progressed, the pain and the diarrhea got worse. I was having chills and fevers. However, I thought with some cold medicine, it would subside. By midnight, I felt delirious. I don't remember what my temperature was. I do remember my daughter rushed me to the Summit Hospital. And by this time, I couldn't answer even some basic questions. The nurse took my temperature and I was immediately admitted into the hospital. I remember they put an IV and I believe they gave me some liquid medicine. I was told at some point I had pneumonia. Since this was my first time experiencing pneumonia, I didn't know what to expect. I was just frightened by the whole experience. I didn't want to eat, but I was told if I didn't, it would get worse. It seemed like everything I ate went through me. My legs were cramping and it was difficult breathing, but I fought hard to breathe. I was fortunate I had no pre-existing health issues, and I did everything the doctors and the nurses told me to do. My temperature, sometimes it would stabilize and then it would rise up again. Every time I would go to sleep, I would dream of someone that had transitioned begging me to come. My dreams became nightmares. I explained my symptoms to the doctors and nurses, hoping that they could give me some other type of medication. I thought maybe the medication was causing me to feel hysterical. By Sunday, the diarrhea seemed to stabilize. The fever broke and my temperature was normal. On Monday or Tuesday, they released me from the hospital, but I couldn't return to my cousin's house because Kaiser diagnosed her with COVID-19. She was not hospitalized, but she was quarantined at home. I had no place to go. My daughter registered me at the nearest hotel in Emeryville, which after several days of less than 1% occupancy, they had to shut down. So we immediately had to come up with a plan. The hotel was forced to shut down. Consequently, we masked up and flew me back home to Las Vegas. The following Monday, Summit notified me with the results. I had the virus. I told them I had returned home and gave them the information about the flight, etc. Then Clark County notified me as well, and I remained quarantined for over 3 weeks. There are residual effects, such as occasional backaches, leg cramps, and shortness of breath. I get tired a lot easier or a lot faster, and I don't think I'm as sharp as I used to be, but I'm determined to keep going. I am monitoring my health, and I've learned to take deep breathing exercises and meditate every day. And I try not to stress about anything. And to be honest with you, I'm just thankful to be alive.
Amen. Well, thank you very much, Ms. Postman. We are certainly glad that you are alive. And thank you for sharing your experience and testimony today, because we don't want anyone to have to experience what you've experienced if they can't avoid it. So thank you again. There are no questions at this time in the queue for Ms. Poston, so we're going to move on to our second panelist, and that is Dr. Kim Rhodes. Dr. Rhodes is an associate professor of epidemiology and biostatistics at the University of California, San Francisco, and the director of the Office of Community Engagement at UCSF. She's also a member of the COVID-19 Equity Task Forces in both San Francisco and Alameda County. When it became clear that the COVID-19 pandemic was affecting communities of color harder and that the rate of infection was higher in the Black communities and spreading quicker, Dr. Rhodes spearheaded a community initiative that brought some of the first pop-up testing sites to San Francisco and then to parks and churches in the city of Oakland. Prior to her work on the pandemic, Dr. Rhodes' research focused on cancer and how the quality of care could be directly associated with disparities in survival. On a personal note, I serve as a treasurer of Tabernacle Community Development Corporation in San Francisco, and Tabernacle was one of the organizations Dr. Rhodes worked with to deliver COVID testing to the Bayview Hunters Point neighborhoods because of her staunch advocacy. And just yesterday, she was presented with an award by the Abundant Life Ministries of UCSF in recognition of her significant contributions to the Black community in the Bay Area. Please welcome Dr. Kim Rhodes.
Thank you so much for that very complimentary introduction, and thank you also for inviting me to be part of this panel. And Ms. Poston, I really appreciate you sharing your story, because it's typical, and if people don't see that, then they aren't aware that of how severe it can be and how quickly things can set up. So today I wanted to just give a kind of a brief overview and some basic understanding of COVID-19 so that it'll set hopefully the context for the rest of the discussion that's going to happen around the vaccine. So I'm going to share a few slides, and as was previously suggested, please feel free to put questions in the chat as we move along. So first, I just wanted to point out that the virus itself is not the China virus, and it's not the Wuhan virus, and it was not engineered in a lab in Wuhan. This graphic is showing the genetic code. So this blue bar here at the top is the genetic code for the virus. There's one part of that genetic code that tells that gives the instructions for how to make what's called the spike protein. I'll come to that in a second. That's sort of the key for the virus to get inside the cells. If you look very closely at the spike protein along this pink bar here, this is a magnified version of this, just a small domain in here, which is defining how the human SARS-CoV-2 is a little bit different than the bat version of the virus. And I'm showing this and not for everybody to understand a whole bunch of information about DNA, but to just show you the closeness of the human SARS virus that we're CoV-2 that we're dealing with now, how close it is in its patterning to the bat virus and to other coronaviruses that caused what we know as SARS and MERS. So this is an evolution of that same family of coronaviruses, not an engineered virus, as some people had suggested in the past.
Dr. Rhodes, can I just ask you if you can expand your screen? We had one comment.
Sure.
Yeah. There we go.
That I'll put it on.
Yep. Thank you.
So as we've heard a lot about how the virus spreads, I just want to remind people it spreads in the air by coughing, sneezing, and also just by talking. And then it can also be absorbed through the eye. And I think that's important because we haven't really emphasized the use of face shields as much as we probably should. The eye is pink mucosa can also absorb the virus. So by touching mucosal surfaces like your nose, your mouth, or your eyes, the virus can be inoculated through there. And then of course, close contact, shaking hands, as well as touching surfaces that have viral particles on it can force the spread of the virus. I had a slide in here about surfaces, and I just do want to make the comment that in the studies that we have so far, we know that the virus can survive on surfaces for up to 3 days. It survives better on plastic and metals. It doesn't survive as well on cardboard and paper. But that's important as you think about yourself in the grocery store and touching surfaces that have been touched by others with COVID. So how does it cause COVID-19? How does the coronavirus itself cause COVID-19? As I mentioned, it has these little spikes. That is why it's called the coronavirus. They're like the spikes of a crown. Those spikes act as a key. Some of your cells have a very specific lock that fits that key. So the virus uses the key to get inside the cell. Once inside the cell, it opens up and shares its own genetic material and effectively tricks your cells into making more virus using the virus's genetic material. So the real prevention is to keep the virus out of your cells. Once your cell's made a lot of virus, the cell extrudes a bunch of viral particles, and then all of those viral particles with their little keys go circulate around your body and look for other locks that fit that key. So in the lungs, and we heard a little bit about pneumonia, but more about, you can also have this kind of effect in the intestinal tract, as we heard from Ms. Poston. But what happens is the virus invades the cells in the back of the throat, and it migrates its way down into the, through the windpipe into the small air sacs in the lungs. Once it's in those air sacs, it inflames the wall. So normally what would happen is you can see there's a thin lining between, this is the inside of the air sac, you're breathing oxygen into your lungs, that oxygen passes to the bloodstream to give oxygen to the blood, and then the blood is circulated around your body with oxygen. It depends very closely on this little divider between the blood vessels and the air sac of being thin so that the oxygen can pass very easily. But what happens in COVID is it causes inflammation, which thickens the distance between where the air is and where your blood vessels are looking for oxygen to come through. It makes it difficult for oxygen to pass through those sacs into the blood. And that means you're getting less oxygen into the blood, and you get the sense that you have a shortness of breath. So who's at risk? In the beginning, we thought we knew. We said, well, so people with comorbidities, it's elderly people, people who have a weakened immune system. But what we know now is it impacts young people, healthy people, and kids as well. And so basically, we're all at risk. In terms of disparities, you probably heard a lot about it, and you may hear more from other panelists today. But what's really important is that the death rates, not the infection rates, but the death rates and the cases of severe COVID are highest in racial and ethnic minorities, as well as those in low income or low resource groups. This is important because the vaccine is actually targeted to reduce severe COVID and to reduce death. So the reality is this vaccine is expressly for the problems facing racial and ethnic minorities, particularly African-American people in Alameda County, particularly African-American men who have a higher risk of death once infected. So the vaccine itself is actually for us. So there are more vaccines on the way. There are two. You'll probably hear more detail about them on the rest of the panel. But I want to point out that the phases of trials for vaccines typically finish after phase 3, and that's when humans can then receive the vaccine. And that's where we are now. But I also want everyone to understand that when the vaccine is being given to the general population, there are still studies ongoing. So even though the initial studies may have only included somewhere between 50 and 100,000 people who got the vaccine as, you know, what some people think of as guinea pigs, the reality is the other 20 million people who have been vaccinated, we are also following them to see what their side effects are and what any long-term consequences are. So for those who have not gotten the vaccine or are worried about being a guinea pig, the reality is you're not a guinea pig because there are 20 million people who have now gone before you. So how does the new mRNA vaccine work? The vaccine functions, I think of it like a personal trainer. So once injected, it's a small piece of the genetic material that contains the instructions for making the spike protein. Your body then makes these spike proteins, which are not attached to a virus. It's just the key. And the reason it's just the key is because the idea is that your immune system will now make antibodies against that key. It will recognize what the key looks like and will make antibodies that will actually glom onto the key. And so imagine trying to get into your house with your key, but there's a big wad of gum wrapped around it. It's not going to fit into the lock. That's how the antibodies work. They gum up that key function of the virus. So if your body ever sees the virus, those antibodies will be activated and will gum up the virus's ability to get into your cells and start the process of infection. So I'm going to wrap it up there. I think others will probably talk about how to figure out when it's your turn to get the vaccine. And I'd be happy to take any questions.
Thank you very much, Dr. Rhodes, for simplifying and explaining in understandable manner the particulars around the vaccine itself, because as we know, what I refer to as the Tuskegee syndrome, that there's a lot of fear as a result of the Tuskegee experiments and people taking a new vaccine that is seemingly yet, or there may be questions about, because it was developed so quickly, how can it be safe? And if you could perhaps just talk about the research that the COVID vaccine virus has been built on, that was taking place, years ago when the first SARS came out. So could you help us understand that a little bit?
Sure. Actually, the investigator who was advancing this mRNA technology really was doing the majority of her work in the 90s. There was a lot of enthusiasm around this idea that if you had the genetic code for different things, you could create antibodies that could stop whatever the code is coding for. But it's interesting because we have this impression, and it's really because of the title warp speed, that this is really new technology, and it's not. And in fact, in the late 90s, this particular investigator lost her funding because the university where she was, I believe she was at UPenn, decided that, well, this isn't really working, so we're just going to kind of toss it aside. She kept working at it. So really, it's been more than a decade in development. So it wasn't really in warp speed. It just happened that we had a solution that finally found its problem, which was COVID. And as a side note, there are now advancing studies to look at using mRNA vaccines for multiple sclerosis. So the warp speed component is just how quickly we got a vaccine for a specific disease in this time frame that we've only known COVID for a year. But the actual investigation of that technology is more than a decade old.
Great. Thank you so much for that. We have a couple of questions in the queue. Tommy Lindsay is asking, how long does one have to wait to get the COVID-19 vaccine after having other injections? Is there a correlation between getting the COVID-19 vaccine and any other vaccines, the flu vaccine as an example, or any other type of injection?
I am not aware that there is, for example, a cross reaction or something terrible that would happen if you had both vaccines. But what I will say, having had the vaccine myself and having had side effects for a couple of days, what I would suggest is you wouldn't want to be dealing with those kinds of side effects at the same time as you may be dealing with similar side effects from the flu vaccine. But I don't think there's any contraindication, meaning there's no true guideline that says don't get these two vaccines at the same time. And I will, of course, defer to Dr. Lenore and his expertise in immunology to add to that. But what I do also want to say is it is still important to get a flu vaccine. And the idea there is to prevent getting the flu, which could be confused with COVID symptoms or signs of COVID. And so we have to protect ourselves from both, because having flu and COVID together would simply be a disaster.
Okay, very good. Thank you so much. And Keith Carlisle is asking, can you speak to the margin of error involved with the virus? Now, I'm assuming, I think maybe with the vaccine itself, so.
Well, and I think he might also be referring to this conversation that's been going on about the variants, the different virus, I don't know what to call them.
Mutations.
They're mutants. Effectively, their DNA code is not exactly the same as the original code that helped create the mRNA vaccine. And so what we know so far is that against what I will call the traditional variant, the Pfizer and Moderna vaccines are somewhere between 94 and 96% effective in blocking severe COVID and death. But against the variants, there is a slight diminution or a decrease in the effectiveness. And I just want to say, again, the variant that we think originated in South Africa, there haven't been any studies in the variant that we think originated in Brazil. But what I will say is there was a paper, Nature just came out this week, showing that when they engineered the variant, meaning they incorporated into the genetic code of what we call a pseudovirus. So they engineered a virus, and they incorporated the mutations from the UK variant and then from the variant that we think originated in South Africa. Then they took the serum, the antibodies from 20 people who had been vaccinated with the Pfizer Moderna vaccines. And they found that those sera that they drew from the patients were able to neutralize the mutations that are present in the variant that we think comes from South Africa. So even though it's slightly lower than the 90% and above that we're used to hearing about, it's still effective against that variant from South Africa. We don't have studies yet against the variant that we think has arisen in Brazil. So that's forthcoming. I also want to just set some expectations a little bit, because I think we think everything in medicine is 90% or should be, close to 100%. And I just want to point out that the polio vaccine, which was very effective, right? We don't know a lot of people who have polio or who contract polio. It was only 50% effective. Mm-hmm. And so when we hear the Johnson & Johnson number of 57% effective in South Africa, when tested in South Africa, and the Johnson & Johnson is on the horizon for us, probably will emerge in March. I don't want people to think, well, I don't want that one because it doesn't work that well against the variants, because it works as well as the polio vaccine did or better, which means that it will be effective.
Great. Thank you so much for your presentation and your comments. Let me remind folks to please put their questions in the Q&A box by clicking on the little Q&A icon at the bottom of your screen on a computer, and maybe at the top of your screen if you are on a tablet. And so now it is my distinct pleasure to introduce my dear friend, Dr. Michael Lenore, who is a nationally recognized expert on asthma in inner cities with more than 47 years of medical excellence. When he said that he had been practicing a long time, he didn't really want to reveal that he had been practicing for 47 years. But for 20 years, Dr. Lenore was the director of allergy services at San Francisco General Hospital, where he worked on asthma issues in underserved communities. Dr. Lenore is a veteran and spent 10 years in the U.S. Army, where he rose to the rank of lieutenant colonel and served as an allergy consultant to the 6th Army area. Dr. Lenore has served as the president of the Ethnic Health Institute at Alta Bates Summit Medical Center and as a member of the board of directors of Children's Hospital. In 2013, he was inducted as the 114th president of the National Medical Association, the oldest and largest national organization representing the interests of more than 32,000 African-American physicians and the patients they serve. A recipient of the American Medical Association's Pfizer Positive Physician Award, Dr. Lenore was named one of America's leading African-American physicians by Black Enterprise Magazine in 2001, and one of the best physicians in the San Francisco Bay Area by San Francisco Magazine in 2001 and 2002. Please welcome Dr. Michael Lenore.
Well, thank you so much. Sounds more like an obituary than introduction. But I want to thank certainly the Council of Negro Women, who was very dear to my mother's heart, one of her favorite organizations. Brother to Brother is legendary in the Bay Area. And certainly my personal thanks to Dr. Kim Rhodes for all of the work that she has consistently done, not only in the area of COVID, but in the area of cancer. And it seems like wherever there is a problem, there is Dr. Kim Rhodes. So thank you very much for the opportunity. And to Ms. Turner, Ms. Watkins Tart, I know the challenges of being the public health director for Alameda County could not be easy during this period of time. I want to spend my time basically in 3 areas. One is, why is the COVID virus so lethal to the African American community? The other is the whole issue of frequently asked questions when we do programs on the COVID virus. And the third is let's talk about what the virus and vaccinations mean to the African American community. One of the things that is always talked about when African Americans are talked about is, are we different? Are we different so that the COVID virus affects us differently? And the answer is absolutely no. We were the first responders. I know when they talk about first responders, they talk about the nurses and the doctors, and they certainly should be applauded. But the first responders were really the early bus, what Jesse Jackson called the early bus first responders. The people who worked in stores and the janitors and people who worked around the nursing homes, the people who worked in driving buses and that encountered the public initially and had no idea this virus was around. Last year in December, I was in New York. In January, I was on a cruise. And February, I was in Las Vegas. And I really, I was following the virus, or the virus was following me. But in Las Vegas, I did get very sick. And we'll talk about what that meant. But it didn't look like I had the coronavirus, but I think I did. But in any event, so that's one of the reasons. The other reasons is the whole issue of what we call health equity. African Americans in general, regardless of socioeconomic status, are just sicker than other people. They're sicker because of a number of social determinants of health. We live in crowded spaces. We don't get the same level of care that other people get. And racism, the impact of racism on the health of Black people has never been quantitated, but we all know. We wake up every day and say, here we go again. At least we got rid of Trump, so that's one little factor that we don't have to worry about, but well, not quite. Don't worry about as much anymore. But the impact of racism on the health of Black people has not been quantitated, but is a real issue. So we were first to encounter the virus. We were sicker when it got here. And so consequently, our morbidity and mortality statistics are the same. There are a couple of frequently asked questions when we talk about the virus. Most people want to know, obviously, as Dr. Rhodes has explained, this is not a new virus. I mean, if you look at viruses like trees, let's say pine trees, all pine trees have the same trunk. They just have different branches. So if you build something against the trunk of the tree, then when you have to build it against one that has different branches, like the coronavirus, you're way ahead of the game just to begin with. The second thing is the vaccines are designed to give you immunity. And when you get tested for two things. You usually get tested to see if you're infected, or you get tested to see if you've been infected. So one of those two tests is always of some availability to you. And you have the opportunity, I think, to get tested now in a much more rapid fashion than you did before. How long do the vaccines work? Well, we really don't know yet. Some postulate that these vaccines will work for 2 or 3 years. But we know, like the flu vaccine, you got to get it every year. And it's a requirement because we don't know which flu, and it's not nearly as effective. But when they do these research projects, it's 94 to 95% effective after you've gotten the second dose. And so that means that most people will be affected by the vaccination. Dr. Rhodes did explain to you about the nature of this vaccine and the fact that it is a RNA vaccine. A lot of people have already had that vaccine, and I think that so it's not new. It's not a new vaccine. And when she talked about polio, that was very interesting. We had an effective vaccine for polio for 50 years, and the last case of polio was described this year. So it took 50 years to get rid of polio. So those of us who are counting on herd immunity, I mean, we better get out of the pasture, because it's not going to be easy to establish herd immunity for this particular virus because most people have not seen this virus and will be vaccinated. One of the good statistics that came out this year is probably the number of people who've been affected is more like 100 million people rather than 25 million people, because most people who get infected a lot of them don't have symptoms, and a lot of them don't get tested. So that does mean that there will be more people protected. But let's look at and we can talk about some of the other questions as they come up. But let's look at this issue. And first let me say, as a doctor, I respect those of you who decide not to get, after getting proper information, decide not to get a vaccination. I've already had my 2. I was trying to get 3, but they said that wasn't going to help me anymore than just getting 2. And I got the vaccination for a number of reasons. First of all, because the option for the same quality of life that you have is gone if you don't have a vaccination. You will not be able to go to a religious gathering, a jazz concert, a baseball game, a birthday party, a funeral, because there will be somebody there like you who is not vaccinated and can pass the virus to you. And so consequently, everything that you do after this, beyond this space, is going to be impacted by the fact that you don't have the virus. I would be very surprised if pretty soon airlines and movie theaters and all these other places are going to make you show your card to show that you've been vaccinated. Now we're a long way from there, but I mean, that certainly is a possibility. The second thing is this virus is very smart. You don't realize virus has been here for millions and millions of years. I think they were just exploded with the Big Bang 13.8 billion years ago. They know how to do it. They know how to get inside you. They figure it out. And if they break up and find another structure of that virus, they're going to be a mutant. And mutants in this particular, the Brazil, the UK mutant, and then the mutant from South Africa, maybe not more dangerous, but they're certainly more infectious. So if you're not vaccinated, where are you going to go and be comfortable? And are you going to be permitted to do other things? Maybe, maybe not. Well, you say, well, I didn't get my vaccine for my children. I mean, and they are okay. They are okay because everybody else around you is vaccinated. But that's not the case with the coronavirus. So you just have to make the decision. And I respect your decision as a doctor. And we live with that decision and we'll try to help in any way we can. And the second thing is when you get the virus, if you get it 10 years from now, 20 years from now, you may have the same experience Ms. Poston has. It's not going to be any different, maybe worse, because there may be more variants that know how to do some other stuff. Clean. I always think this virus is outside waiting for me. Every time I get out of the driveway, it's going to learn to cook this virus will learn to do a lot of things. And any vaccination protects you somewhat from the more serious effects of the virus. And so consequently, I think that's a decision that you have to make. I think that we do have a justified paranoia about what's going on in this country. But when I look at these statistics and see 2.6% of the vaccinations that have been given to African Americans, I see two things. I think, first of all, they already forgot about George Floyd, so they're not focusing on us anymore. We're not as popular as we were in the summer where everybody wanted to kind of build up the equity. They should have targeted this virus vaccination program toward the African American community. They really did not do that. So that's the first thing. And the second thing is that people are just kind of afraid that something is going to happen. But I do think that from what I've seen so far, I made a personal choice based on the information that was in front of me, and I respect your choice. But at the same time, I think the quality of life for me to go see my grandsons, for you to go to a baseball game, are more important to your religious gatherings and funerals and things that you do with your family is going to be significantly altered if you're not vaccinated. And so with that, I'll stop and see if there are questions. But I think that we, as those of us who believe that vaccines are important, have to do a better job of messaging. The African American community is pretty smart. I mean, we didn't get here over the middle path. I always tell people that we're very genetically selected because only a few people made that middle passage. So that gave us a basis of wisdom, strength that other ethnic groups in this country do not have. We survived slavery, we survived all these other things. So when you make the decision not to get a vaccination, I assume you've gotten the information. It's to you a wise choice, and I respect that.
Thank you very much, Dr. Lenore, and we appreciate your insights. There have been a number of questions that went into the queue, and most of them have been answered, but there are two that are waiting for a response, and I want to ask a follow-up question. You made the comment that the testing and vaccination efforts should have been targeted at the African-American community, but they were not. Now that we know that, if you know better, you can do better. What is the African-American, physicians, nurses, public health officials collectively doing, and this may be a better question for Ms. Watkins-Tart, but what are they doing to address that so that the equity of now vaccinations are getting to the African-American community at the same ratio they are with the broader public?
Well, I go back to one person, Jim Clyburn. He saved President Biden. And I think what we're starting to see now is that people recognize that there were not these targeted programs. Now, what you have to, when I do want to explain, and I'm sure Ms. Watkins would explain, every county and every state had to do their own thing. Like Alameda County, they say was a little slower than others, but Alameda County is a very complex county. It's not like, with some of these other counties where you can just do this and do that and make these decisions. And I think they did target the African-American and high-risk communities. But across the country, we're just starting to see that people know that we have to really ramp up the resources and the messaging to the African-American community. And hopefully that will be done. I just think that's just an example of how quickly they forget how guilty they felt in the summer. But I think now we're starting to see many more programs targeted. At least I'm seeing on CNN and my sources. Dr. Watkins-Tart will know more about that than I do. But I didn't see when it was rolled out, I did not see they talked about us all summer, how more at risk we were, how we were dying every time you saw a news report. It was there. But when they rolled out this vaccination program, I just didn't see it specifically targeting. the African American community.
Okay. Thank you, sir. Trayshawn Anderson is asking the question, I feel like the Moderna vaccine has done a better job at being inclusive in their sample than the Pfizer vaccine. Is that true?
Well, the reason I selected the Moderna vaccine is that, every time you add a dynamic to something, it increases the risk, what we call asymptotically, that something's going to go wrong. You got a vaccine that got to be frozen here and frozen there and moved around and rotated 5 or 6, 7, 8 times, then as opposed to one that they can just deliver and give to you, then I think it reduces the chance that there's going to be a problem. I haven't seen or heard of any really serious problems, but this Pfizer vaccine really requires a lot of comfort. I mean, we used to say that the Pfizer vaccine needs to be placated at every level. And so I thought the Moderna vaccine, with about the same efficacy, with less manipulation to get it to me, was a choice that I made. But both vaccines seem to be effective.
Okay, thank you very much. Aaron Ortiz is asking Dr. Lenore, for communities of color, should we start considering that this is an endemic?
Well, I think it's a pandemic because it's not going to be the only one. And every time a pandemic comes, those communities that are less healthy, those communities that are affected by social determinants of health, like poor nutrition and housing, and lack of exercise and lack of access to health resources that are high in quality and consistent, will be affected by any infection that comes through. I'm sure that you went back and looked at the pandemic of 1917 or 18. Trump confuses me so many times, but I think it's 1917. I think you would find that African Americans really were devastated by the Spanish flu. It just was not pointed out at that time, nor did anybody care. So I think this is just one, it's not the last pandemic. And I think every time a pandemic comes, we're going to see somewhat the same thing, not because of genetics, but because of the social determinants in which African Americans find themselves, not only for health care disparities, but for health disparities, but for the way they're treated in the system once they get these infections.
Excellent. Well, thank you very much for your comments and insight, as well as your decades of service to the health and well-being of the African American community. And keep the questions coming, by the way. We've just keep them coming. We're going to get to all of them. Some are being answered by the panelists in the Q&A, but we may go back and ask some of the other questions that have already been answered, so that everyone can get the benefit of those. Our next panelist is Ms. Kimmy Watkins-Tart, and she is the Public Health Director for the County of Alameda. Ms. Watkins-Tart is responsible for providing overall administrative direction, planning, and organization of the programs and operations of the Public Health Department. She has worked for more than 25 years in the local health community and was instrumental in helping the Community Health Services Division design and implement its health equity and local policies. Ms. Watkins-Tart also spearheaded Alameda County's first chronic disease prevention planning process. Her long-standing passion and commitment to health equity and social justice is clear. Ms. Watkins-Tart is a founding member of the Bay Area Regional Health Inequities Initiative and served on the Health Equity and Social Justice Committee of the National Association of City and County Officials. Please welcome Ms. Kim Watkins-Tart.
Good morning, and thank you. It's been really nice to hear all of the panelists, my colleagues, and fellow Alameda County residents, speaking about their experiences with this. And I appreciate being invited to talk about this. So let me share my screen here. Okay. Am I there? There we go. All right, perfect.
Looking good.
Okay. All right. So I want to just start with just very briefly with some data of where we are right now. So as of last night, and our dashboard is on our website. And it's updated daily. As of last night, we had 77,926 cases of COVID in Alameda County with 1,088 deaths. This dashboard, as I mentioned, is updated daily, and you can go to it and see every day how things are coming along. I'm going to talk more about really the policies behind the vaccine rollout and what we're doing in Alameda County, and hope there will be conversation about things that we can do differently. We're still very early in the vaccine rollout, and so there's still a lot of opportunity to make changes. So the two most recent changes that have happened is that as of February 8th, Alameda County moved into phase 1B, tier 1, which essentially includes all those who are 65 and older, also includes essential workers who are in food, agriculture, restaurant, also includes emergency service workers and education and childcare. The other addition that just happened yesterday, the state just announced that healthcare providers may use their clinical judgment to vaccinate individuals ages 16 to 64, who they determine as being at very high risk for morbidity and mortality as a result of severe health conditions. They go on in their notice, and you can find this information on the state's website, to list several health conditions that they will consider being severe, such as cancer, chronic kidney disease, chronic pulmonary disease, Down syndrome, immunocompromised states, pregnancy, sickle cell disease, heart conditions, severe obesity, and severe diabetes. There's a lot of controversy over this particular move of the states. There was a lot of advocacy from community groups, particularly from the disability community, to ask the state to really take into account that there are individuals who are younger but sicker, or who are more vulnerable and really need to be able to get vaccinated earlier. The challenge right now and the pushback is that many of the advocacy groups are saying that this is not soon enough. We need to include these individuals now, not March 15th. The other concern, and I share this concern, is that if you don't have a regular source of care, how will you get the determination? And so that is a logistical and administrative challenge that we're going to have to work through, because this could be a wonderful opportunity for many, many people, but it could also leave out a lot of people, particularly in the African American community, if we don't have a source of care, a regular source of care, where we can get the documentation to determine that we have health conditions that would allow us to get the vaccine earlier. So we in Alameda County are going to be working through the logistics of this, of how do we do this so that we don't have growing disparities in the implementation of this. So we also recently added a dashboard for our vaccines in Alameda County. And so we will be improving this dashboard as we go along. This is just very early, but as of last night, we had administered 223,212 doses, and this is first and second doses. And these data do include the city of Berkeley. The city of Berkeley is a separate health jurisdiction, but there are times where we will report data for the entire Alameda County geography. As you can see in the slide, whites and Asians have really outpaced most other groups. And we believe that this is a function of having rolled out vaccine to the healthcare providers first, our healthcare workforce. And so African Americans make up roughly about 13%, the data that we have, 13% of the healthcare workforce. Unfortunately, we were vaccinated at only about 7%. And so we have seen already that there's disproportionality already there. We are expecting that this will change because the healthcare workforce is not really reflective of Alameda County demographic necessarily, but because of what my colleagues have said earlier, health disparities and health equity and health inequity is not new to our county. And so we should not think that COVID will be different. We should be assuming that there will be disparities if we don't do things differently. So I mentioned earlier, this is just more detail about where we are in Alameda County. What I want to also share with you is that, again, right now the supply is not sufficient for everyone who wants a vaccine. And it's important that we know that there isn't yet enough vaccine for everyone who may want it. And so even within the phases and the tiers that the state requires us to stay within, we are going to be prioritizing so that we can ensure that people who are the most vulnerable have the vaccine. So for Alameda County, we're asking, so this is how we're going to be prioritizing in county run pods or points of dispensing. And we're asking healthcare providers in Alameda County to also prioritize in this way. We will not be able to police all of the healthcare providers and to ensure that they prioritize in this fashion, in this blue section down here, but we are asking that we all prioritize older adults, that we prioritize those with Medi-Cal or who are underinsured or uninsured, that we prioritize people who live in those zip codes that we've been talking about this whole year that have been disproportionately impacted by COVID. Those zip codes are largely in West Oakland, East Oakland, and the unincorporated area of Ashland, Cherryland, as well as a small pocket in Livermore. We are asking to prioritize people with direct contact with clients or the public right now. People who cannot work from home. Everyone does not have that luxury. Dr. Lenore pointed out that those first responders are transportation providers, the people who work in the grocery store. They have been working and with the public the entire time, including in the beginning without masks and without protection, without PPE. We also want people to prioritize those with limited mobility. In Alameda County, we have stood up a community advisory group to help the public health department to shape our vaccine distribution efforts. I'm happy to say Dr. Rhodes is a member of our community advisory group, and really we are fortunate to have such a diverse group of stakeholders throughout Alameda County to help us to think about messaging, help us to think about how we build trust, help us to think about just how we make sure that people have access. Our intentions are always good, but implementation can also be very difficult. And it's really important to get information from the community about how we make sure that what ends up hitting the ground is implemented the way in which we envision it. Our county is involved in several vaccine efforts throughout the county, the Oakland Coliseum, Alameda County Fairgrounds, as well as Buchanan Parking and Golden Gate Fields, Fremont High School, and I'll speak more about Fremont High School in a moment, Santa Rita Jail and emergency services workers, There are also what we're calling fire pop-ups. And these are collaborations between the fire department as well as our clinical providers in mostly the South County area. And one of my colleagues is on the call now watching, Aaron Ortiz, Executive Director of La Familia. And Aaron's organization is also participating in some of these community-based efforts in the unincorporated in Ashland, Cherryland, South Hayward area. Community health centers, Kaiser, Sutter, Stanford Healthcare. Many people have heard about the megapod or the large vaccine distribution effort that's going on at the Oakland Coliseum. We were in the planning phases of setting up vaccine at the Oakland Coliseum when the federal government launched this new initiative to partner with the state to have large vaccine efforts. And so our Coliseum vaccine site has been federalized, if you will. And so what's good about this is that they are committed and have promised to bring and be able to vaccinate up to 6,000 people per day. And those 6,000 doses will not come out of the Alameda County allotment. Right now, Alameda County receives about 14,000 doses per week. We're talking a possibility of 42,000 doses per week. And so that's a significant increase in supply coming into our geography. We also have, in a partnership with Stanford Health, we also will be standing up a large vaccination site at the Alameda County Fairground. I want to show you some data from the first couple of weeks of our vaccine sites. And this, remember, was when we were vaccinating mostly healthcare workers, but this shows again what I showed in the earlier slide of who was vaccinated, mostly whites and Asians. And although we represent about 13% of the healthcare workforce, our vaccination percentage was about 7.3%. So we do have much work to do. I want to switch really quickly now to talk about a model for vaccine distribution that we have piloted at Fremont High School. And so we took a page from our community testing, contact tracing, and case investigation efforts from earlier on this year, where we partner with community-based organizations, residents, and other advocacy groups to bring the service to the community at the neighborhood level. And so we stood up a new pod or community pod at Fremont High School. And this is just a picture of the layout of what it looks like. It's indoors, and so it's inside of their gym. And this has been a wonderful partnership with both the staff and faculty at Fremont High School, as well as Oakland Unified School District. And so we are set up to dispense 640 doses per day at this particular location. And so what I would like to turn to, though, is what makes a community pod very different than some of the other dispensing sites. We know, and this has been pointed out earlier, that there are many, many, many barriers and many reasons why the health outcomes are not the same for everyone. Language, the logistics of accessing services, transportation, feelings of safety in all the ways that people want to feel safe and need to feel safe, accessibility, technology, just general information so that people can make informed choices, hours of operation, as well as a history of racist medical practices. Those have really contributed to all of these things, really make it a challenge to provide services to people to close those gaps. And so the kinds of things that we are doing currently in the Fremont High School site, and we will be doing in all of our other community pods, having weekend time slots. So right now the Fremont High School site is open Thursday through Saturday. Having same day appointments. Most places, in order for you to get a vaccine, you have to go online and you have to register for an appointment. For Fremont High School, we have that, but we also have drop-in. And so we set aside some of the appointments and some of the vaccine for people who just walk up and say, I want a vaccine. And if they meet the criteria, they're in the right phase and tier, they will be vaccinated. We are also prioritizing people from certain zip codes. And so what that has meant is that at Fremont High School, we've actually turned away people who were from other zip codes, not in that neighborhood, not in Oakland, not from the most impacted communities. And it's a hard thing to do, to actually say, no, we're going to prioritize these individuals from these neighborhoods in these locations. But we believe that it makes a difference. We're partnering with community-based organizations to help with the outreach and the engagement, as well as the pre-registration. For the people who do register online, many of them will need help navigating the technology. And so partnerships with community organizations is critical for that part. Also, we've been able to share information on social media. We created a video explaining to people in both English and Spanish how to access the registration appointment site that is available. Lastly, having medical staff on site who can answer questions. We would like to add to our vaccination pods a Ask a Doctor, Ask a Nurse for people who come with a person who's going to be vaccinated, but they themselves either may not be eligible or they're not sure that they want to get vaccinated. And we want there to be an opportunity for them to get information about the vaccine so that they can be thinking about it and considering whether or not they will get the vaccine when it is their turn. This is just an example of some work that we've done with putting together a video explaining how to use the technology. I also want to share with you a bit of the data from our Fremont High School site. And essentially what this data is showing is that when we set up the site at Fremont, we had far fewer people coming from out of jurisdiction, so outside of Alameda County. We also saw that most of the people were from Oakland, which that's who we were aiming for. We also saw that most of the people, 41%, were from those priority zip codes. And what's most significant about this is that when we offered walk up, we got an increase in uptake of African Americans at 28%. And so what this is telling us is that this model, it works. And we need to do this and use this approach for all of our vaccine sites. Some things that we're considering moving forward, contracts for multicultural and linguistic support, culture keepers, outreach needs, volunteer medical providers that are reflective of the community. One of the things that has been very difficult is having enough clinicians who really look like the people who are in the neighborhoods that we are in. We think that that's important. And so we are asking our clinicians who want to come out there with us to partner with us to show the community that we are part of the medical community as well. We also want to connect residents with other resources, enroll them in health insurance and other benefits, as well as the in-person registration at high traffic locations in targeted areas. So what that could mean is that we might set up a kiosk for registration at a grocery store to let people know, do you want to get a vaccine? Go here, register right now, and then you've gotten your appointment taken care of. And so we're still kind of thinking about the logistics of how that would work, but those are the kinds of things that we're thinking about. Our next stops are Deep East Oakland and Ashland Cherryland, and we hope to be able to partner with many of you in this call as we identify the next sites for our community pods. Thank you.
Thank you very much. That was extremely informative. And I have a number of questions for you, but Dr. Lenore has a interview with KTVU in a few minutes, and there was a specific question that was addressed to him. And so it is related to people with severe allergies. Should they get the vaccine, or what precautions should they take? What questions should they ask in preparation to receive the vaccine? You need to unmute there, Dr. Lenore. Still muted. Do I need to ask you to unmute? Let me see.
Pressure on me.
Oh, there you go. There you
Don't
go.
put the pressure on me like that.
Okay.
My wife is always trying to mute me, so I'm in a permanent state of muteness. But the recommendations are that people who've had anaphylactic reactions to vaccines before not get a COVID vaccine. Now, the confusion is that it doesn't mean if you have an allergy, just a simple dust allergy, grass allergies, seafood allergies, and other allergies, that you shouldn't be considered for the immunization. Unfortunately, in our office, we can test for some components of the vaccine. The polysorbate component of the vaccine, we do have a test for. We can't get enough vaccine to test people to see if they are reactive to the vaccine on the skin test. But I do think that unless you have had a serious reaction to a vaccine, you should consider not getting that vaccine. If you do decide to get it, it's because you're in a high risk group, or you want to make sure you do it at or near a hospital situation. So in case you have an anaphylactic reaction, somebody's prepared for it. But we can test for one of the components, the polysorbate component in the vaccine. And so, most allergists can do this. I know we can do in our office. We can do it at Columbia. So, but the studies did not give and actually most of those anaphylactic reactions took place in England. There haven't been too many of those reactions here. And I also have some patients who faint when you give them a shot to anything. And so constantly, but if you had a serious reaction to a vaccine, I would consider that this is not a good idea right now.
Great. Thank you very much for taking that question. And we appreciate your contribution to our panel discussion today. Good luck with your interview with KTVU.
Well, I want to say thank you to all the panelists, especially what Alameda County is doing is really quite remarkable, I think, and Dr. Rhodes' contribution. So, and thanks both to Brother to Brother and the National Council of Negro Women for having me on this program.
Thank you very much. So that's a great segue to the question that I wanted to really pose to Ms. Watkins-Tart, and it's working backward just a little bit. I know we're talking about the vaccine, but Alameda County did an exceptional job during the December, January surge of the virus. Most of the other counties in the Bay Area had no hospital beds left for COVID, and Alameda County was consistently performing much better. What did you and your team specifically do to make that a reality for the citizens of Alameda County?
So, this is a collective effort. Managing COVID and keeping people safe has been a collective effort. It has taken the public health department, every healthcare provider we have in Alameda County, colleagues even across the Bay, like Dr. Rhodes. It has taken all of us, really. And I think that expanding our case and contact investigation work to community-based organizations has made a big difference, because we've been able to reach people very quickly to interrupt the chains of transmission. Also, Alameda County has quite an expansive community testing program, which is inclusive of Dr. Rhodes' Umoja work as well. And so having testing available to people in the places that they feel most comfortable is enormous, and it makes a big difference. And so we are still testing about almost nearly 10,000 tests a day in Alameda County. And even though vaccine was on the horizon, we didn't stop testing. We're still pushing that people need to get tested. We need to isolate, we need to quarantine. We provided isolation supports for people. So when people test positive and they don't have cleaning supplies and masks, we deliver through community partners those supplies. And I don't want to leave out the big support that the county provided in the Arch Stipend program to provide about $1,200 to people who didn't have any paid leave. They didn't have any other kind of unemployment insurance to cover them in order to isolate. And what we saw early on is that when people would test positive, they would still go to work because they didn't have any paid vacation or paid leave. And so paying people $1,200 to stay home and take care of themselves, I think that makes a big difference.
Great. Thank you. Thank you very much for that question. And your colleague, Mr. Ortiz, is giving you a shout out there saying, thank you so much for consideration of the community pods. He said it'll be crucial in serving our community. So a little thank you there. We've got question about, it's probably for Dr. Rhodes, what are the ingredients in the Moderna vaccine? We know it's a protein, but can you break that down a little bit for the audience?
Yeah, so it's basically the mRNA strand itself, which is the genetic material, the instructions for your body on how to make the spike protein to trigger your antibody production against the spike protein. And then that mRNA is surrounded by a layer of 2 lipids, which is just fat or oils, and some salts to kind of hold that lipid layer together. And the reason that that's there is because mRNA is very, very fragile. There are what we call RNases that like kill RNA when they see it. That's, around you right now on your desktop, on your computer, on your fingertips. So the lipid layer protects that mRNA until it gets into your body. And then the lipid layer goes away, and then the mRNA starts to train on how to make the spike protein, and then your antibodies recognize that. That's also why that lipid layer is called lyophilization. It's why the vaccine has to be kept so cold, because that's what holds the oil and the salts together.
I see. Great information. Thank you for that response. We have another question from Howard Woods. This is rather detailed, so I'm going to have to read it verbatim here. It was first proposed by French scientist Antoine Beauchamp, who most Americans have never heard of. The current mainstream theory of disease that has been instilled, taught, and permeated throughout the Western world's population is called germ theory. Beauchamp was able to see bacteria and other nanomaterials emerge from the cell as opposed to coming from outside the cell, like most people have been taught. Do you have any, it's more of a statement than a question, but do you have any thoughts on that comment?
Well, I have a lot of thoughts about it, because it really, that discovery of germ theory got rid of the idea of miasma and contagion, that things are just kind of floating in the air and kind of make you sick, and we don't really know what they are. But it also had an unfortunate consequence, in my opinion, is in that it split medicine from public health, because what happened was people who were training as sort of health practitioners, as a general broad category, doing prevention work, once germ theory emerged, then you start to have the opportunity to become a physician or to stay in public health practice. Because now we could say, well, if there's one germ, then there's going to be one cure. And that really came with the advent of discovery of penicillin. And so what happened in America is that we became healthcare focused, like, oh, well, if you get a problem, we'll just treat it, right? Versus we should prevent the problem. Mm-hmm. You see that in the underfunding of our public health systems and kind of our overinvestment in healthcare. And what coronavirus has really shown us is that the two need to work together, because in order to save the hospitals from ruin, remember the toilet paper shortage, right? Mm-hmm. Hospitals have the same problem. If everybody wants the same resource at the same time, the hospital is going to run out of that resource. So for COVID, we really should be focused on prevention in order to save the healthcare system. And so, yes, that is true. Germ theory, revolutionized our ability to treat things, but it also turned our focus to healthcare rather than public health. And right now, we really need public health.
Thank you. Thank you very much for that. My next question, let me pull those up. And I wanted to pose this one to Ms. Watkins-Tart. It seems like there's an almost endless flow of funding available to address the COVID-19 pandemic on the one hand. On the other hand, counties, cities and counties in particular, are experiencing a significant decline in sales tax revenue as a result of restaurants being closed, businesses being closed. And so where is the funding coming from to support all of the activities that Alameda County Health Department is engaged in to combat the COVID-19 virus?
Thank you for that. I think, the last year has been COVID and budget. And so the public health department, I'll start with the public health department, our funding is mostly a patchwork quilt of grant dollars and a small amount of local general fund dollars. We've been pretty fortunate that we've been able to use our general fund dollars, repurpose them in order to support our COVID response. In addition, our county has been really, I think, very supportive, our elected officials, around the use of CARES dollars that, every jurisdiction makes its decisions about how they use those federal funds, but really our county prioritized COVID. And so it was through the CARES dollars that we were able to stand up and execute all of those testing contracts for community-based testing. It was the CARES dollars that we were able to open up all the isolation and quarantine hotels. There were other dollars in there as well, but those kinds of resources our county has really prioritized for our response. We've also gotten some funding through the state, which helped us to extend our contracts with community-based organizations who currently are performing a lot of our contact tracing and outreach and health education efforts. And we just got notice that we will receive another large portion of funding from the state to enhance our efforts. And so while the general fund picture does look a little bleak, we've been able to use the resources that have been made available and not had to fight to hold on to those resources for our COVID response. But our county is also very frugal and cautious about the use of funding in general. And so I think we went into COVID in a pretty good situation financially, and especially our public health department definitely did.
Great. Thank you. Thank you very much for that and for just the outstanding job that the County of Alameda is doing under your leadership to address the virus. We're talking about the virus, but there are still questions that revolve around the testing. There are two primary types of tests. Dr. Rhodes, would you discuss the difference between the two, the antigen test, and the other one is escaping me at the moment, but you know what they are. So can you help us understand that, please?
Sure, I'm going to add a third category. So there's tests for acute viral infection, and then there's tests for whether or not you've had the infection in the past. And I think Dr. Lenore sort of alluded to that. I'm going to talk about the test to see if you've had it before is an antibody test. Remember, the idea is after your body has seen a foreign invader, it makes antibodies to it. So we can test to see if you have antibodies. That doesn't tell you if you've you are acutely infected today, it tells you that you were infected sometime or exposed in the past. So I want to set that one aside. So the two tests that I think you brought up, one is the antigen test and one is the nucleic acid test. So one is testing for the nucleic acid test, which is commonly known as PCR, polymerase chain reaction, is testing for the genetic material of the virus. So it's looking specifically to see if it can find the genetic material that tells you the virus is currently present. The way that genetic material turns into other things is through a process of what we call transcription and translation. You don't need to remember those words, but what it means is it changes a string of letters, that is the nucleic acid material, into proteins. So antigens are proteins. So the antigen tests, which are mostly what the rapid tests are based off of, are looking for a step beyond, yes, the virus is present. It's like, is the virus now invading your cells and having your cells make the materials that look like the virus? The parts of the virus are the protein, just like your muscles on your body, that's protein. So one is good for people who have symptoms because the infection has been running for a little bit of time. And that's the antigen test. That's those rapid tests. They're looking for production of the virus. PCR can detect the infection earlier because it's looking for just the presence, the signature of the virus in your body. It's not looking to see if anything has happened since the virus invaded your body. It's just asking, is the virus there? So the PCR test is the gold standard and it is the most accurate. The antigen test is less accurate because it needs the infection to go on for a little bit of time before it can detect it. So it detects it later. And also, if you don't have symptoms and you don't have a lot of virus circulating in your body, the antigen test can tell you you're negative when in reality you're positive. So the best way to use the antigen test is if you're getting tested every single day with the antigen test. So that would be good for schools, for example.
And both of those tests are administered with a swab in the nose. Is that correct?
Not necessarily. So at Umoja Health pop-ups now, we're using the saliva-based PCR. So we're getting a saliva sample, which is collected by the person. You could do this at home yourself through a straw into a tube. Then we perform PCR looking for the genetic material of the virus. So that's still gold standard and does not require a swab.
Okay, great.
Can do PCR with a swab, but it takes longer. So we can get our saliva-based test results back in 24 hours. Whereas with the swab, you have to take the swab out of the tube and then process the liquid and then get all the genetic material out of it and then run your PCR. With the saliva, you can just run the PCR using the saliva as your sample. So they don't all require a nasal swab. Antigen testing currently does require a nasal swab as well.
Great, great. Thank you so much. Ms. Watkins-Tart, in your presentation, you mentioned all the resources that are available to citizens of Alameda County. Could you put the website in the chat that our participants can go to find out the answers to further questions they may have, or where those pop-ups are located, where the vaccination sites are? So if they decide to get one, they can put themselves in the queue. We would appreciate that. There's a question about, since you mentioned it, I guess, can an asymptomatic person test negative and still pose a risk to others?
Yes, unfortunately. 60%, well, okay, technically it was 59%, but basically 60% of the spread of the virus is now thought to be from asymptomatic people to others. So the vast majority of the spread is from asymptomatic people.
Okay.
I think this is an important point. I have a little graphic that shows this idea around Thanksgiving about someone who wanted to go to their Thanksgiving gathering. So they had a test after being exposed. They had a test on day 5. It was negative. So they thought, hooray, I can go to my Thanksgiving gathering. They went to the Thanksgiving gathering. After the Thanksgiving, they had another test, which turned positive. So during the Thanksgiving gathering, they were infectious to the rest of their family. And it's just making the point that if you're exposed, your test can turn positive anywhere from 2 days to 14 days from the time of the exposure. And that's why we ask people who are questioning whether or not they have an infection because they've been exposed to quarantine. And that time frame is to allow for, if you're going to turn positive, that you turn positive, and then your body combats the infection before you're out talking to other people and interacting with folks. So 2 to 14 days is from the time of exposure. Your test could be negative on day 2, negative on day 3, 4, 5, 6, 7, etc. It could turn positive on day 14.
So it's because of that, the fact that the infection can manifest itself over a period of 2 to 14 days, that we should still wear masks regardless. Is that
absolutely
accurate statement? Okay. So what about cancer patients, people who are currently in treatment? Is there any research that shows the benefits and or risks of getting the vaccine for them?
So there is no, and I actually reached out to one of my medical oncology colleagues who will be giving a talk, and we'll share the link with you all about the vaccine and cancer in April, I think. And none of the trials included people with a known diagnosis of cancer. However, ASCO, which is the American Society of Clinical Oncology, is recommending that people with a diagnosis of cancer get the vaccine. The only caveat or warning is for people who are in treatment with chemotherapy, which can suppress the immune system, not get any vaccines that are based on live attenuated virus. For right now, we don't have any vaccines like that are approved. So Pfizer and Moderna are safe, thought to be safe by the American Society of Clinical Oncology for people who have a diagnosis of cancer.
Okay, thank you.
So the answer is yes.
Yes. Okay.
Stick with the 2 we have for people with cancer.
Right. So along those similar lines, the question has been raised. What if a specialist says, don't get a vaccine because it was only tested on healthy people, and then later says, take the vaccine now, as science may have not known the ramifications for people with underlying conditions? So the fundamental question is, what would you recommend? And I know that's a complex question, but.
Well, it's complex because the truth about science and the truth is mutable. Remember, the earth used to be flat. It's right. We know it's not flat. So what I would say is, go back to what I said in the beginning, nearly 20 million people in the United States have been vaccinated, and all of those people are being followed in terms of, what side effects they're having. And of those 20 million people, they're not all healthy or without comorbidities. So we do actually have information on people with comorbidities, and the trials were not just conducted with healthy people. So, on one hand, you could say when that first assertion about healthy people was made, we didn't have the other 20 million people. Now we have those other 20 million people. So it's okay that the recommendation appears to have changed. And my recommendation would still be to get the vaccine if you have the opportunity.
Okay. So with regard to getting the vaccine, the guidance that you mentioned in your presentation, Ms. Watkins-Tart, is that it has been revised to include those under the age of 65 in that kind of second tier with pre-existing conditions. So are there any specific steps that group of people need to take in order to get vaccinated versus the 65 and older group?
Thank you for that question. So the new guidance will go into effect March 15th. And so between now and March 15th, we will get more instruction from the state, and we will be having conversations locally in Alameda County to determine all of the logistics of what kind of documentation are you then bringing to a vaccine site. Are we telling people, well, we would prefer that you get your vaccine from your medical provider because they have access to your medical record, they can make the determination, and then they administer the vaccine? Are we saying that you get a note from your medical provider and take it to a community vaccine site? So all of those administrative details still need to be worked out. And so, yeah, I don't have an answer to other than the fact that it's not available yet. It's March 15th is when that group will be eligible, but we will have more guidance about exactly what does that mean. And what if you don't have a doctor?
Right.
Who then will make that determination for you?
Okay. That's very helpful. And again, keep the questions coming. I've got a few more in the chat here. Ms. DeVera Hurd is asking, this might have been answered, but what is the youngest and what is the oldest one should be to take the vaccination? Dr. Rhodes?
So I can answer the youngest. I don't actually have a concrete answer for the oldest. The youngest for the Pfizer is 16 years old. The youngest for the Moderna is 18. I don't know, Kimmy, if you have a guideline for the eldest. I'm not sure about.
We haven't put out any age limit at the top end, no. And I haven't heard anything suggesting that we should either.
Sure. Okay. What about the Johnson & Johnson vaccine, although it's not approved yet? Dr. Rhodes, I think it was you that mentioned it should reach emergency authorization in March. Is there any benefit to waiting on the Johnson & Johnson, or should you get the vaccine as soon as you can, whichever vaccine is available?
Well, before the Biden administration announced that they were ordering 200 million doses, which I hope really comes to fruition, because what that means is the shortage that I've been really hammering on the need to talk about, that there aren't enough vaccine doses for everybody. And we should adjust our expectations and our behavior and continue testing and doing everything that we were doing before. So I'm encouraged that there are more doses. But what I would say is, until those doses materialize, I'm still functioning like there's potentially a shortage. So if you get offered a vaccine, whether it's Pfizer, Moderna, J&J, AstraZeneca, Novavax, you should take it. The advantage of J&J, one huge advantage for public health is it doesn't require that cold chain storage handling. So it's going to be much easier to administer in mobile sites, for example. And it only requires one shot.
Okay.
So I think that's the benefit. It is not an mRNA vaccine. It's sort of an old style vaccine where they take a virus that causes the common cold. They empty that virus out of its genetic material, which helps it cause the common cold. And instead they insert genetic material that helps to train your body against coronavirus.
Excellent. Thank you. Thank you for that. And I know we talked about the PCR test, but there is a question asking to explain the test cycles. Please.
Okay, I think Kimmy wanted to add. Kimmy, were you adding?
I wanted to actually make sure, and I think you covered this in your presentation, Kim, but I think it's important for people to know why they still need to mask and social distance themselves, and really, limit those those social gatherings, because I think you touched on it a little bit, but I do think that the audience needs to really know, what do we know for sure about the vaccine, what it can do, and we're still waiting, So do you want, I'm sorry.
No.
You didn't ask the panel to ask questions, but I want to make sure that we don't leave here without someone speaking to that.
I'm
Yeah,
glad
I
you
think-
did raise that. Go ahead, Dr. Rose.
I think what you're getting at is that the vaccine does not prevent you from getting COVID. I don't know if everybody's aware of that. And I think that's a really important point. It prevents moderate to severe COVID, and then severe COVID and death, hospitalizations, intubations, and death. That's really where the prevention is. So what it means is you could get infected with COVID after you've gotten the vaccine. You just won't get as sick, but it also means that you could potentially give it to someone else. And so after you're vaccinated, your mask wearing is to still protect other people from sharing your COVID. And especially if they're not vaccinated, because then their case of COVID has a higher chance of being severe or deadly. So I think that's it's super important, because it's not like other vaccines where it really prevents the disease altogether. The way we prevent the disease altogether is that so many people are vaccinated. And as Dr. Lenore referred to, this herd protection or herd immunity, by having everybody vaccinated, that's when the virus goes away.
Okay. Thank you for that clarification. And along those lines, there's a question I'd like to know: how long does the vaccine last?
Mhm.
I know Dr. Lenore kind of alluded to the fact that it may last a couple years, 3 years. That like the flu vaccine, you have to get there's a new strain annually that you get. So, there any information on the length of inoculation that occurs from a vaccine?
Yeah, so I guess I would refer everybody to our present living history, right? We've been with COVID for a year. So we don't know anything about 3 years from now. We've been with the vaccine for 3 months.
Mm-hmm.
So we don't know, and I guess you could count the trial data. But if the trial started 9 months ago, what we know is up to 9 months. But we don't know how long it's going to last. And my boss, Dr. Kirsten Bibbins-Domingo, who's the chair of the Department of Epidemiology and Biostatistics, some of you may have heard speak in other arenas. She did on a webinar we were on together yesterday say, I anticipate that people will need a shot every year, just like the flu.
Okay. So, couple of practical questions. If someone has COVID-19, they've experienced it and they've recovered, how long should they wait before getting the vaccine?
There are no recommendations for a specific period of time, because remember, when you have COVID, you actually have the virus in your system. The vaccine is simply giving your body a glimpse of a part of the virus. So it's not a true infection. It's simply a training for boosting up your antibodies against the spike protein. So there is no specific recommendation for that. Obviously, if you have had COVID-19 and you're recovered, the real issue is we don't want you out and about until you're no longer infectious. So we don't want you to show up at your vaccine appointment with COVID, because then you're putting everybody there at risk, since you're going to have to sit there for 15 to 30 minutes after your shot. And it's usually in being given in indoors. So if you have COVID, we really don't want you indoors with other people breathing.
Okay, excellent. And then, thank you. The other kind of follow-on question to that is there any correlation between getting a flu vaccine and getting a COVID vaccine? Should there be a distance of, time between the two, or are there no guidelines for that as well?
Yeah, again, same thing, no guidelines, but with the side effects, if you get side effects from your flu vaccination mixed with side effects from COVID, you'll feel terrible. So you can space them apart, but do plan to get both.
Okay. So we're nearing the close of our time, and certainly appreciate all of your contributions. I'd like to just ask Ms. Watkins-Tart to give some closing comments before we turn it back over to Ms. King, I believe, or I think it's Ms. King. Let me check my notes. Yes, it is Ms. King. So closing comments that you have for our guests today.
So the goal for our public health department and my goal is to make sure that everyone, and definitely all African Americans, that we really take advantage of as much information as we can get our hands on, high quality information about the vaccine. Ask all of the questions you need to ask, because at the end of the day, we really do want everyone to get vaccinated, but I want you to make an informed decision. I don't want you to just follow what someone else said, and I don't want you to just base your decision on gossip and hearsay. Take advantage of all the information that's available to you, make an informed choice, and really consider getting the vaccine. And if you've already done so, talk to others around you who haven't decided and tell them why you decided to get the vaccine. The way that Dr. Lenore shared, I got the vaccine because. That makes a difference. And let's keep having venues like this where we can talk it through and chew on this and think about it. The distrust of the medical system is real. The medical system in the United States has done abhorrent things to lots of people. And so we have a long haul to overcome a lot of that.
Thank you very much. You made some poignant comments, and I think to a large extent, as I referenced the Tuskegee syndrome earlier, there is a fair amount of distrust with the medical delivery system in the US, particularly in African American communities and communities of color. As we do that, I'll say that I did get the shot. I was a beneficiary of the extra, because I'm not in the category, but they had met the criteria for which these doses were provided, and they had extra, and I was fortunate enough to be able to be one of the recipients of the extra, both my wife and I. And I think our rationale for taking the vaccine was to protect other people. We're both healthy individuals without any comorbidities, but we want to protect our family. And so that was our rationale for doing it. After doing a lot of research to decide, because I was one of those who said, I want to get it, but I'm not going to be in a hurry. And so I was thinking, in the summertime maybe. But when the opportunity came up, I took advantage of it. So we got two more panelists to hear from, Dr. Rhodes and then Dorothy Poston. So.
I was answering the question about PCR cycles in the Q&A, because somebody had a concern about false positives. And what I wanted to want to emphasize is that the danger is not a false positive on a PCR, because if you get a false positive, you will be told that you're infectious, you will isolate and stay away from other people, which prevents the spread of the virus in general. The issue is false negatives, where you think you're not carrying the virus, but you are. What I would just remind everybody is the reason that we have these new variants is because people are moving around and sharing the virus with each other. The more times the virus duplicates itself, the more mistakes it makes. And those are the variants that we're getting, the mutations, the mutated versions of the virus. So I would just really caution, and I'm so appreciative, because I think Alameda County has been conservative in how we, quote, reopen, compared by comparison to San Francisco, where I also work. And I think that conservative kind of messaging around reducing how much activity and how we come in contact with each other really is truly in service of the public health around this virus. So I would close with the idea that we all do want to get back together, and that is coming, but we need to be a little bit patient in how we get there so that we can reduce the number of people who get infected, especially knowing that of those who get infected, it is African-American people, particularly African-American men, who have the highest chance of dying from the infection.
And so one final question for you. how long after receiving the vaccine are you, fully inoculated to the 95 percentile group?
You're at 50% when you're halfway between your first and your second dose. So at the time of your second dose and shortly thereafter, you should be at 100%. But remember, what does that mean? You're still wearing your mask. You're
Right.
still distancing. You're still washing your hands.
Okay, very good. And finally, we have Ms. Dorothy Poston, who has experienced COVID-19 and survived. And again, we are grateful to the Lord that he kept you healthy and got you through. Amen. So can you just share your thoughts, closing thoughts with our participants today?
Yes, I would like to share my appreciation to everyone that was on the panel. I think we need to have more conversations like this to help those of us who've already experienced the virus, and even for people who might be suffering. I've lost many family members, and I'm sure you all have, as well as friends. So these type of discussions is very important, and I appreciate you all just allowing me to be on the panel. And I'm thankful to be alive. Thank God. Thank you.
Amen. Amen. Well, with that, I want to give my thanks to each panelist for participating on behalf of the National Council of Negro Women, the Oakland or Oakland-Hayward Section, and Brother to Brother. I'm Kevin Blackburn. It has been my pleasure to facilitate this discussion today. We hope that you came away with some knowledge that you will be able to use as you make a determination whether or not you answer the question to get vaccinated or not to get vaccinated. So thank you again, and I will turn it over to Ms. Jennifer King for closing remarks. Oh, and also let me just say this. These things don't just happen because somebody gets an idea and says, hey, we need to, have a town hall. There's an awful lot of work that took place behind the scenes to put this town hall discussion together. And so I just want to acknowledge the committee members from both the National Council of Negro Women and from Brother to Brother. And with that, Ms. King, the floor is yours. Do you need to unmute? Yes, you do.
There we go.
There you are.
Thank you, Kevin. Good afternoon, everyone. On behalf of the National Council of Negro Women and Brother to Brother, we'd like to thank each of our audience listeners for taking time out of your busy day to participate in this virtual town hall. Both organizations are positive that you've heard something this morning that you can share with your family, friends, and members of the community. It does us absolutely no good to have life-sharing information and not share it. So please pass this information along. We want to thank our fabulous panel of speakers for providing us with such high quality and expert information. And they did it in such a way that we could all understand it. And for that, we thank them. Thank you to Dorothy Poston, Dr. Kim Rhodes, Dr. Michael Lenore, and Kimmy Watkins-Tart. You're all doing a fabulous job in our community, and please know that we hold you in the highest esteem for doing so. As Kevin said, this morning's presentation was brought to you through the collaborative efforts of two phenomenal organizations, the National Council of Negro Women and Brother to Brother. Our Brother to Brother team members, including the outstanding host, Mr. Kevin Blackburn, and the electronic expertise of Brother to Brother, Blaine McFadden. Also on that Brother to Brother team was Merlin Edwards and Fred Turner and Mr. Freeman McFadden. We thank you, gentlemen. The NCNW committee members included our section president, Carolyn Hewitt, Reverend Dr. Martha Taylor, Reverend Annette Carter Peoples, and myself. So thank you, ladies, for a wonderful job. A recording of this event will be available on both YouTube and on the East Oakland-Hayward Section's website, eohncnw.org. Again, I thank you all for your participation. And on behalf of NCNW and Brother to Brother, we want you all to stay healthy and to stay encouraged. Now would be a great time for you to grab a pencil and a piece of paper. And immediately following, you're going to get some valuable information about both of these wonderful organizations. We encourage you to reach out to the organizations. They both love to hear from you. Again, thank you and have a wonderful afternoon. Thank you for reminding me. There's a very brief questionnaire. If you take a moment and answer that.
Okay.
Be careful, folks. Your mics are still on.
Okay.
Thank you, everyone. That concludes our webinar.